Now we'll move on to the classification of genetic diseases. So genetic diseases are basically classified into 4 main categories. So first one, which follow the Mendelian laws. So they are Mendelian disorders. Then we have non-Mendelian disorders. Then we have chromosomal disorders. And lastly, we have multifactorial inheritance. So under Mendelian, we have autosomal dominant, autosomal recessive, X-linked dominant, X-linked recessive, and Y-linked inheritance. Under non-Mendelian disorders, we are going to have 4 main categories. First is the mitochondrial mutations. So mitochondrial DNA mutations are going to be there. Then trinucleotide repeat mutations. Then genomic imprinting. Then finally gonadal mosaicism. Then in the chromosomal disorders, we can either have a structural defect or a numerical defect. So the structure of the chromosome can be affected, or the number of the chromosome can be either deleted or increased. So monosomy or trisomy. So those are numerical defects. So again, it can either be present, the numerical disorders can either be present in the sex chromosomes or in the autosomal chromosomes. So these are all chromosomal disorders. Under multifactorial inheritance, we are going to have both genetic and an environmental basis. So based upon the genetic susceptibility, adding on to which there are some environmental insults which is going to cause a particular disease. So the examples of multifactorial inheritance are cleft lip, cleft palate, congenital heart disease, diabetes mellitus, hypertension. So all of these are going to be examples of multifactorial inheritance. So let's start with Mendelian disorders first. Under Mendelian disorders, we'll read about autosomal dominant and autosomal recessive side by side. Okay. So autosomal dominant is going to be the most common mode of inheritance, while autosomal recessive is usually the most common mode of inheritance for inborn errors of metabolism. So any enzyme deficiencies, so those kind of inborn errors of metabolism, autosomal recessive is the pattern of inheritance. So usually autosomal dominant disorders tend to present in adulthood. So adolescence or adulthood is the time in which the autosomal dominant disorder manifests, while an autosomal recessive disorder usually manifests in the childhood itself. Okay, so childhood onset. While the penetrance in the autosomal dominant is going to be incomplete penetrance along with variable expressivity in autosomal dominant, it is going to be complete penetrance and 100% expressivity in autosomal recessive. So what is this penetrance and expressivity? I will tell. So penetrance is the one in which particular genetic mutation is going to be there in an individual. So the genotype is that of the disease, but the person is not going to express the trait. Okay, suppose in an autosomal dominant disorder, so in autosomal dominant disorder, it is usually every generations are going to be affected. So the grandfather would have had the disease, then the father would have had the disease, but the child, the third generation, the child wouldn't have manifested the disease. So, but if you check his genotype, he is still going to have the mutant gene. So the mutant gene is there, but the expression of the mutant gene, that is the trait, has not been expressed fully. So it is called as incomplete or reduced penetrance. So incomplete or reduced penetrance is a feature of autosomal dominant disorder. So coming to variable expressivity, it is the same as pleiotropy kind of only. So in variable expressivity, it is actually single disease is going to have variable manifestations in variable people. So again, Marfan syndrome, if you take, so that gene is going to be fibrillin gene mutation only, but still the manifestation, one of the person is going to have Marfanoid habitus, some other people will have cardiac defects. So this kind of a difference in the manifestations is going to be there. So that is called as variable expressivity. So variation in the expression of the trait is called as variable expressivity, which is again a feature of autosomal dominant. So pleiotropy was a single gene having a different manifestations. Okay, so in autosomal recessive, there is going to be complete penetrance along with 100% expressivity. So remember this. So this again we had read about this. So in autosomal dominant, the trait is going to be expressed both in the homozygous state and in the heterozygous state. While in autosomal recessive, it is going to be expressed only in the homozygous state. to remember the genetic disorder, so you'll have to, they'll give you pedigree charts for solving the diseases, right? So for this, you'll have to remember certain mantras. So for autosomal disorder, dominant disorder, remember it is all generations are going to be affected and all genders are going to be affected. So both are going to be all. So every generation will be affected and all the genders are going to be affected. While in autosomal recessive, there is going to be skipping of the generation, but here again all generations will be affected. So let's see the pedigree chart here. So here if you see, here this is the affected male over here. So this is female and this is the male. Okay, square is male and circle is female. So this is how the pedigree chart will be given, and you will be asked to answer the questions in the MCQs. So in the first generation, there is a male who is affected, and they have given birth to 4 kids, and out of this, again, a female is affected and also a male is going to be affected over here, and they are affected in the second generation also and the third generation as well. So here both the female and the males are affected and all the generations are affected. So this is the classical pedigree of a autosomal dominant disorder. While in autosomal recessive, here if you see, there is an affected male in the first generation while his kids are all normal, and the kid has married a normal male again and they have given rise to another normal family, and then that normal kid has actually given birth to disease personalities in their generation, and they are going to be both female and male. So both male and female are affected, but generations are being skipped over here. So this is the classical pedigree of an autosomal recessive disorder. So the best examples of autosomal dominant disorders are usually structural protein defects. So structural proteins, the genes encoding for them will be defective in autosomal dominant, while enzymatic deficiencies like in inborn errors of metabolism. So these are going to be examples of autosomal recessive disorders. So let's see the examples. Again, examples of these genetic disorders are very, very important. So they can ask you as a direct one-liner, or they can give you the pedigree and they'll ask you one of the examples in the options. Okay. So in autosomal dominant, we have a mnemonic like he has a very dominant father. So the word dominant is coming here. So you can remember it like that. Autosomal dominant, he has a very dominant father. So let's see. He stands for hereditary spherocytosis. It is going to be a anemia or hemolytic anemia, hereditary spherocytosis. Has, for that you are going to have Huntington's disease. So here Huntington gene is going to be affected. Then we have autosomal dominant polycystic kidney disease, and then we have von Hippel-Lindau syndrome and von Willebrand disease. Then for D, we are going to have muscle dystonias. Then O for osteogenesis imperfecta, wherein collagen is going to be defective. Marfan syndrome here again, there is fibrillin gene which is going to be defective. Then we have intermittent porphyria, which is a porphyria group of disorders. Then we have both neurofibromatosis type 1 and type 2. Then we have achondroplasia, in which the classical history will be a very short person. So having both upper limb and lower limb which are quite short. So this kind of a thing will be given for achondroplasia. And tuberous sclerosis. So tuberous sclerosis has multiple manifestations, including cerebral tumors and renal tumors also. Then we have familial hypercholesterolemia, then familial adenomatous polyposis, and Lee-Frommeny syndrome. So Lee-Frommeny syndrome is a genetic mutation in which P53 gene is going to be mutated, resulting in n number of cancers in the family. Familial adenomatous polyposis again will result in colonic cancer. The gene mutated here will be APC gene. So familial hypercholesterolemia is actually a inborn error of metabolism actually. So it is the only exception in which it is inherited as an autosomal dominant disorder. Okay. So familial hypercholesterolemia, usually you have enzyme defects, but here it is still a autosomal dominant disorder. So the examples are important. So now let's see the autosomal recessive pattern of inheritance example. So here we can have all kind of biochemical enzyme deficiency you must have studied. No? So most of it is going to be autosomal recessive. So phenylketonuria, alkaptonuria. Then we'll have sickle cell anemia, thalassemia, which are blood-related anemic pictures, cystic fibrosis, CFTR mutations, hemochromatosis again, Wilson's disease, liver diseases basically, albinism, So these are all enzyme deficiencies. Alpha 1 antitrypsin deficiency causing a liver and lung disease. Then congenital adrenal hyperplasia. Then lysosomal and glycogen storage disorder. So entire table you read, right? So all of that, those were enzymatic deficiencies. So those are again examples of autosomal recessive. So here again we have some exception. So in glycogen and lysosomal storage diseases, everything is going to be autosomal recessive except for Fabry's disease and Hunter's disease, which are going to be a X-linked recessive disorder. So Hunter's and Fabry's disease are going to be X-linked recessive, while familial hypercholesterolemia is going to be autosomal dominant. So these are exceptions for this rule. Okay. Now let's see about certain autosomal dominant disorders. So the first example of the autosomal dominant disorder is Marfan's syndrome. So Marfan's syndrome, here the gene defective is going to be the FBN1 gene, which is going to be present on chromosome 15. This is going to encode a fibrillin protein. Okay, this FBN1 gene is going to encode the fibrillin protein present on chromosome 15. So here this fibrillin protein is going to have a dominant negative effect. So there is something called as dominant negative effect. Here this again is an MCQ. So dominant negative effect in the sense, this fibrillin gene is this fibrillin protein, its actual function is to form a scaffold for elastin protein. Okay. So only when fibrillin is there, elastin can properly fold and form the proper protein. Okay. So fibrillin is the scaffold for elastin. But when fibrillin is defective, it is going to cause the abnormal defect in the elastin as well. So elastin was actually normal over here. Only the fibrillin is being affected. But still, fibrillin being defective is going to affect the elastin as well. So this is what we call it as a dominant negative effect. Okay. So fibrillin is the dominant one here. So without that, so dominant negative, it has been lost. So dominant negative effect, it is going to affect some other normal protein function as well. So because the scaffold is not being formed here. So the examples of this dominant negative effect will be seen usually in Marfan syndrome and also in osteogenesis imperfecta. So in osteogenesis imperfecta, it is the collagen which is usually defective. Okay. So collagen, we all know it is a triple helix, right? So triple helix is going to be there. But if there is only one collagen chain which is affected, so only one chain is being affected in the collagen, but still the helix cannot form. So for the helix to form, we need all the three chains to be proper. So even one chain is defective, the proper collagen is not going to be formed, resulting in the osteogenesis imperfecta. So this again is an example of the dominant negative effect. Okay. So there is something called as haploinsufficiency also. So haploinsufficiency, again we'll take the example of osteogenesis imperfecta here. So suppose there is an allele here and there is another allele. So both alleles form the thing, right? So both the alleles have to be present in equal amounts. So both has to be expressed. So both the alleles are going to be present in equal amounts to form a normal protein. Suppose there is both alleles, but one of it is not being expressed. So it will result in the decreased amounts of the normal protein. Okay. So decreased amounts of normal protein because each of the allele has not contributed equally here. So this is what we call as haploinsufficiency. So this again is resulting in one of the disease called as osteogenesis imperfecta. Here again collagen, you can a collagen defect, if you see both the alleles, if they are not being expressed, the collagen is not going to be formed to the proper normal extent. So that is what we call as haploinsufficiency. So haploinsufficiency and dominant negative effect, you usually see it in autosomal dominant disorders. So under Marfan syndrome, we are going to diagnose it based on the revised Gens criteria. So Gens criteria is for Marfan's syndrome. So Duke's criteria was for infective endocarditis, while Gens criteria is for Marfan's syndrome. And Jones criteria is for rheumatic heart disease. Okay. So clinical features of a Marfanoid will be, the history will be given as a tall guy with long arms and then long legs. Okay. And they'll have long fingers as well. This is what we call it as arachnodactyly. Okay. So tall guy with long extremities having long fingers will be given, and they'll have dislocation of the lens. Usually the dislocation is going to be superotemporal. So upper and outer dislocation of the lens is going to be there. And then their joints are going to be very lax. So freely movable joints will be there. So they can bend their thumb like this. So this thumb can come and touch the radius here. So this kind of flexible joints will be present, and they'll have cardiovascular manifestations usually. The most common cardiovascular manifestation in the Marfan syndrome is going to be a mitral valve prolapse. Okay, mitral valve prolapse is be seen commonly in Marfan syndrome. Along with that, they can also have aortic dissection. So the vessels will be weakened. The elastin is going to be weak because of fibrillin defect, right? Dominant negative. So because of that, the vessel elasticity is going to be lost, resulting in aortic dissection. Okay. So now let's see about the Ehlers-Danlos syndrome. So Ehlers-Danlos syndrome, here it has various types of Ehlers-Danlos syndrome. So it is both autosomal dominant and autosomal recessive based on the subtype. Okay. So here the defect is going to be in the collagen here. Okay. The collagen is going to be defective, and most commonly it is the type 3 collagen which is being affected. Okay, and it is also called as the rubber man syndrome because they are very flexible. So people you see in circus, right? So they are quite flexible. So those kind of people are usually, they'll have some kind of this connective tissue disorder like Ehlers-Danlos or Marfan's. So here they will be very flexible. They can bend the knees anteriorly. So this way they can bend the knees, the thumb. So they have very flexible joints. So they are called as rubber man syndrome. So the most common form of this Ehlers-Danlos type is going to be type 3 EDS, Ehlers-Danlos syndrome. So in type 3 EDS, it is the type 3 collagen which is usually affected. Okay. So type 3 and type 3. Type 3 collagen is most common and type 3 EDS is most common. And this type is going to be called as the hypermobility type. So type 3 EDS is called as the hypermobility type. The least common type is going to be the type 7 EDS. It is going to be called as arthrochalasia. So arthrochalasia is type 7 EDS, which is the least common type. But the most life-threatening type of EDS is type 4 EDS. Type 4 EDS is life-threatening because it is the vascular type. It is going to affect the vessels, resulting in massive hemorrhage and dissections. Okay, so you are going to have vascular type of pathology. So that is the most dangerous one occurring in type 4 EDS. So clinical features of Ehlers-Danlos, again I have already mentioned rubber man syndrome. So they are going to have very highly flexible joints. Along with that, their skin is going to be very, very thin. They are so thin that it is looking clearly transparent. So they are called as cigarette paper like skin. So cigarette paper like thin skin along with hyperflexible joints are classical features of Ehlers-Danlos syndrome. So in the history, they might also give some kind of vascular pathology. Okay, and they'll ask for what type of disease is that. So that will be an Ehlers-Danlos type 4. So now we had seen about some of the autosomal dominant disorders. Now we'll see some examples of autosomal recessive disorders. So first one will be a Tay-Sachs disease. A Tay-Sachs disease is a lysosomal storage disease. So lysosomal storage disease, obviously it will be autosomal recessive because the enzyme which is going to be deficient here is a hexosaminidase A. So hexosaminidase A deficiency is going to be there. So there is going to be accumulation of the substrate on which the enzyme was supposed to act. So this substrate accumulation is going to cause the various toxic manifestations. So the classical history will be given of a cherry red spot in the macula. So this is the optic disc we see, and here, and this is the, if you see here, you are going to see the red color dot here, right? So this is the cherry red spot seen in the macula. Then in the CNS, if you see, there is going to be presence of ballooned neurons. So these neurons are normally supposed to be of this size, but they have ballooned up so much because the substrate has accumulated in these neurons and they have become toxic to this neurons. So all of these are ballooned up neurons which have a very vacuolated cytoplasm. So look at this, it is having a very vacuolated kind of cytoplasm because it is going to contain some fat inside it, and so fat is present, so they can be stained with oil redo. So oil redo positive will be present. in these Tay-Sachs ballooned neurons. And if electron microscopically, if you see, they are going to give a characteristic onion skin appearance. So this onion skinning is usually of the lysosomes. It is a lysosomal storage disorder, right? So this lysosomes are going to appear like onion skin in Tay-Sachs disease. So ballooned neurons, cherry red spot along with onion skinning of the lysosomes is seen in Tay-Sachs disease. Then the next disease is another lysosomal storage disease called as Niemann-Pick's disease. Niemann-Pick's disease is again autosomal recessive disorder caused due to sphingomyelinase deficiency. So sphingomyelinase deficiency, again sphingomyelin, which was a substrate, is going to get accumulated, resulting in toxicity. So here the cells which are storing this is again going to have lots of foamy cytoplasm. Okay, so lots of foamy cytoplasm will be accumulated. These are basically macrophages which are taking up the storage particles. Okay, the storage substrate. So it is the foamy cells will be present in Niemann-Pick, and on electron microscopy here you are going to see zebra bodies. So in this image, if you see, all these are lysosomes which are having this characteristic dark and light band like appearance, right? So these are zebra bodies, and these zebra bodies are not quite specific for Niemann-Pick disease because it is also seen in Fabry's disease. Okay. Then Gaucher's disease is again a lysosomal storage disease. Actually, so it is a autosomal recessive again. Here it is going to be glucocerebrosidase deficiency. So enzyme glucocerebrosidase is going to be deficient. So glucocerebroside is going to accumulate, causing the toxicity. So on storage, if you see, it is going to have a crumpled tissue paper appearance. So this is the cell in which it has been stored, and if you see, it is having some, as if the tissue paper has been crumpled and kept. So the cytoplasm is going to have this characteristic crumpled tissue paper appearance, and these are called as Gaucher cells. So Gaucher cells have that crumpled tissue paper appearance. So if they ask pseudo Gaucher cells, so pseudo Gaucher cells, we see it in CML, chronic myeloid leukemia, which are actually C blue histiocytes. So because of the increased turnover in the CML, there is going to be accumulation of the lipid inside the histiocytes, giving this crumpled tissue paper appearance there also. So that C blue histiocytes in CML, we call it as pseudo Gaucher cells because they look like the Gaucher cells we see in Gaucher's disease. Okay. So in Tay-Sachs, we saw cherry red spot in macula. Along with that, balloon neurons, and electron microscopically, we had onion skinning. In Niemann-Pick, we had foamy cells along with the electron microscopic image of zebra bodies. So zebra bodies both in Niemann-Pick and Fabry's disease. In Gaucher's disease, we are going to have Gaucher cells which have a crumpled tissue paper appearance. Okay. So any of this can be given as image-based questions again. So now we had seen about autosomal dominant and autosomal recessive. Let's move on to X-linked recessive. So X-linked recessive is going to be represented like this. So there is a male here. So this male is a normal male, XY, so capital I have mentioned. And then there is a female here which has having a, this gene is going to be defective. Okay. So this is the carrier female actually. This female is carrier. So if you put the pedigree, it will be XX, XX, XY, and then XY, right? So here, this is going to be a normal female, while this is going to be a normal male, while this here again, it is going to be a carrier female, while here it is going to be a deceased male. Okay. Because here in this carrier female, if you see, that even though this small x is recessive, it is not going to manifest because it is a recessive pattern, right? So recessive, we need it in the homozygous state to manifest. So we still have a normal x here, which is going to manage for this recessive x. So they are going to be just carrier females. But this male, he doesn't have a s. This x is the defective one. But and his being a male, he'll have another y only. He'll not have a normal x. So this x, normal x is not there to replace the function of this defective x. So here this male is going to be deceased. So understood? So this is the deceased male. So in X-linked recessive, you are going to get one deceased male and one carrier female. Along with that, two normal people are going to be there. So this is the pedigree. So the ratio, if you see this for the disease, it is going to be 1:4. Right. So the disease, if they ask, it is going to be 1:4. But if they ask what are the defective alleles, so alleles in the sense even the carrier will come under that, because even 1x is the defective one here, right? So deceased person is 1:4, while deceased allele is going to be 2 here. Okay, 2:4 will be the deceased allele. Okay. So the mantra for X-linked recessive here will be females are carriers and males are affected, like hemophilia, right? So best example would be hemophilia. So females are always carriers, but males are the ones who are being diseased. So whenever they ask any questions like this, put a pedigree, you will get the answer. Okay. So the exception to this rule here, that the females are carriers and males are diseased, is that the females can be deceased in 3 conditions. So firstly, the female can be deceased if there is a Turner syndrome. So Turner syndrome, it is 45XO, right? And this O is already useless. There is no X. And if this X was the recessive allele actually, so this was the X which was defective. So we don't have any X at all to do the function of the X chromosome. So here in Turner syndrome, if this X is going to be recessive, it is going to result in the disease in the female. Then Lyon's hypothesis. So in Lyon's hypothesis as well, we have this X and X. Okay, so this X was the recessive allele. So this is not going to function properly. So normally in the normal female, this X would have compensated for the loss of the seized allele. But in Lyon's hypothesis, suppose this normal X is the one which is getting randomly inactivated. So in that case, there is no X which is being active or proper, right? So there is no X to perform the actions of the X chromosome. So there again, the female will be affected. So another example is when a carrier female, so carrier female will be represented like this, right? This is the defective allele. So a carrier female is marrying a deceased male. Okay, here the deceased male is, they are going to marry. In that case, the pattern will be X, 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 Y, X, X, and X, Y. So in this here, this person is going to be a female carrier again. This one is going to be a normal male. This one is going to be a affected female, because double X, right? So both are recessive, homozygous it has become. So affected female will be there, while here it is going to be a deceased male, right? Because this X is here. So in these 3 conditions, that is Turner syndrome, then Lyon's hypothesis wherein the normal X is being randomly inactivated, and then this carrier female marrying a deceased male in the X-linked recessive pattern, there again, in these 3 conditions alone, a female can be affected. Okay, so these exceptions are again important. So what are the diseases of this X-linked recessive pattern? So we have hemophilias, then Bruton's A gamma globulinemia. So in that again, you are going to have an X-linked defect. Color blindness is X-linked recessive. Then chronic granulomatous disease, you have both an X-linked and an autosomal recessive subtype. Then Duchenne's muscular dystrophy and Becker's muscular dystrophy, both of these are again X-linked. And then Lesch-Nyhan syndrome, Fabry's disease and Hunter's disease, I already told, it's an exception from the autosomal recessive, that one. Then Fragile X syndrome, as the name suggests, there is X here. Then G6PD deficiency, and then Wiskott-Aldrich syndrome. So the examples are again very important here. So all of these are X-linked recessive diseases. So moving on to X-linked dominant disease. So X-linked dominant here, if you put the pedigree in this, you are going to have, so this is the affected allele, okay? Okay, so here it is the normal female is there, and here it is the male which has been affected here, okay? So in this case, so this is the normal male over here. So these 2 people are going to be affected. So both the females are going to be affected, right? It is a dominant disorder. So even one is going to be there, it is going to be affected. So these two are normal male, while these two are affected female. Okay. So here it is the dominant. So X-linked dominant, right? So even in a heterozygous state, it is going to express. So one of the alleles is going to be affected. Here it is the affected female. So what is the pedigree here? It means that the deceased father is going to transmit to all his daughters. So this is the deceased father here who has transmitted the disease to all his daughters, but he had spared her males. His sons he had spared, but he has transmitted the disease to all his daughters. Suppose this deceased female is going to be marrying another normal male. In that case, you are going to have XX, XX, X dash, then XY. So this will be the one. So here this is a normal female. This is a normal male. And here this is an affected female. And here it is an affected male. Okay. So in that case, if you see, it is the dad is going to give the disease to all his daughters while sparing his sons. While a deceased mom is equally giving the disease to both the male and female. That is, both daughter and sons are going to be affected, and only 50% are affected, right? So normal male is there, normal female is there, and there is 50% of affected male and female. So the mantra for X-linked dominant will be: a deceased father is transmitting the disease to all the daughters, while deceased mother is going to transmit the disease to 50% of the offsprings, be it a daughter or a son. Okay. So the examples of X-linked dominant diseases are very less. So we can remember it by the mnemonic Ravi. Okay. So R stands for Rett's disease, A for Alport syndrome, V for vitamin D resistant rickets, and I for incontinentia pigmentae. In this Alport's disease, it's actually all kind of inheritance are present, but X-linked dominant is the most common inheritance. Okay, more than autosomal dominant, autosomal recessive, and X-linked recessive. X-linked dominant is the most common inheritance. So Ravi, we can use the mnemonic to remember X-linked dominant diseases. So the last Mendelian disorder here will be a Y-linked or a Hollandric pattern. So Y-linked inheritance is also called as Hollandric pattern. So here if you see, all the males are going to be affected because Y chromosome is going to be transmitted only to the male, right? So XY is and only a male can have an XY. So this Y chromosome can be given only to another male. So this Y, if that Y itself is being affected, whenever that Y is being transmitted to the kid, it is going to be all the males are going to be affected. Okay. So let's put the pedigree for this. So this is a normal female, and here we are going to have a deceased male. So we are going to represent it like this. So let's draw the pedigree here. XX, XX, XY, XY. So see, here again, it is a normal female. Here it is a normal female again. While this is Y is affected, Y is affected. So both of these are affected males. Okay, affected males. Suppose this guy is again marrying another normal female, same pedigree will come, right? So here again you are going to have XX, XX, XY dash, and XY dash. So in every generation you are going to have affected male, and it is only the males who are being affected. So all males are affected. Simple mantra is all males are affected in Y-linked. So the example of Y-linked disorder Hollandric inheritance is hypertrichosis or hairy ears. Okay, so you see ears, hair in the ears of men, right? So that is transmitted to his son as well. So that is Y-linked inheritance. So let's revise the mantras alone for the Mendelian disorders. So for autosomal dominant disorder, it is all generations are affected and then all genders are affected. In autosomal recessive, it is going to be generations are going to be skipped, but all genders are affected. Coming to X-linked recessive, we are going to have females are carriers but males are deceased. The females will be affected in only 3 scenarios that we saw that. Then in X-linked dominant, we are going to have deceased father transmitting to the deceased to all his daughters, while deceased mother is going to transmit the disease to 50% of the offsprings. It is both to females and males she is transferring. And then for Y-linked, it is all males are affected. So if you remember this mantra, you don't have to even remember this. If you draw the pedigree, you'll get the chart easily.